Hello and welcome to the monthly series of talks on Asian health brought to you by the Center for Asian Health Research and Education and the Stanford Health Library. We're really pleased to bring to you this monthly series of talks with fantastic speakers focusing on Asian health issues. I'm very happy to have Dr. Linda Geng join us today. She will be discussing improving the diagnosis of an underrecognized and rare diseases in Asians. Rare diseases have a low prevalence but are collectively common. They are often under-recognized, and patients can face delays in diagnosis or misdiagnosis. Linda Geng, MD, PhD, will review rare diseases as they relate to Asian health and strategies to improve the diagnosis of these under-recognized conditions. Dr. Linda Geng, MD, PhD, is a clinical assistant professor of medicine whose clinical focus includes diagnostic medicine, undiagnosed diseases and medical mysteries, rare disorders, post-acute COVID-19 syndrome, long COVID. I'm pleased to welcome Dr. Linda Geng.
I'm very excited to be able to speak about the topic of improving the diagnosis of under-recognized and rare diseases in Asians. I am the Consultative Medicine Diagnostic Second Opinion Co-Director, and we are a team-based clinic that tries to help with diagnostic second opinions on rare, puzzling, and atypical conditions. And in particular, as part of this care series of talks, I wanted to highlight some of the important under-recognized conditions and how we're going to try to approach this in improving diagnosis in Asian populations. So the overview in terms of what I'm going to go over I wanted to first illustrate with a real patient case some of the challenges and barriers that patients of Asian descent can experience, especially when they're afflicted with a rare or under-recognized condition. Then we'll talk about the process of diagnosis, which is actually quite complex, and highlight some of the factors that are really important into getting the right diagnosis. Then I'll talk about rare diseases and some of those challenges in diagnosing those, as well as the health disparities that are really important to underscore and to try to make progress on. And ultimately, how are we approaching this both here at Stanford as well as at other places in trying to improve diagnosis and our goals and how the preliminary data that we have from our projects to try to help improve diagnosis of under-recognized conditions in Asian populations. So this is a real patient case of a patient that I had met many years ago. And he was a 40-year-old man, originally from China. He had unexplained progressive blood clots. So he had what was called DVTs, or deep vein thromboses, that went from his calves all the way up into his thighs and into his abdomen, the big blood vessels in his abdomen. These were extensive and they were progressive. He was already on blood thinners to try to treat these blood clots, but unfortunately they had kept growing despite being on blood thinners. And he also, at some point, started to cough up blood. And this is, of course, very dangerous. If you're coughing up blood in the pulmonary system, in your chest, in your lungs, that could be life-threatening. So here was a conundrum, a clinical case of a patient with blood clots. You're trying to treat them and break up the clots. Usually you use blood thinners. On the other hand, he was coughing up blood. When he had undergone imaging, it was discovered that the reason he was coughing up blood, he was had a blood thinner on board, so that was making him more susceptible to bleeding. But B, he also had, and I have a picture of some of the blood vessels that go through the lungs here. He actually had what was called pulmonary aneurysms, which means dilations in his pulmonary arterial system, in his vascular system in the lungs. And he ended up starting to bleed from these. And so this was, he had seen multiple doctors. He was now in a life-threatening situation, and it was really a puzzle as well as an urgency to try to understand what was going on with this patient. And it was finally the recognition that, asking the right questions in his case of thinking about his background as well as thinking outside the box and understanding what other symptoms he had. Turns out he had also a bunch of oral ulcers as well as eye issues and skin issues. And in interviews, with the ability to speak with the patient on his language, his primary language, which is Chinese, we were able to finally obtain that critical information and actually come to a diagnosis. And that diagnosis really saved his life because he ended up switching to a life-saving therapy, which ultimately, actually, instead of blood thinners, was immunosuppression and suppressing his immune system, because he ended up having a condition called Behçet's disease. And Behçet's syndrome, or Behçet's disease, is very complex. This is just showing you the complexity of a rheumatologic condition that can affect the blood vessels, and it causes inflammation of these blood vessels. And really, it's relatively rare in the United States, but interestingly, it goes by another name, and that is the Silk Road disease. So it's not that rare, and not as rare in certain Asian countries. In particular, for some reason, it follows kind of the distribution along the ancient Silk Road, going from Central Asia all the way over to the Middle East. Behçet's is actually named after the Turkish dermatologist who described the first initial cases and the symptoms, the foundational symptoms that define this condition. This case I wanted to bring up to highlight some of the challenges in diagnosis. For example, there were likely language and cultural barriers to be able to get the critical key information to make the diagnosis. But also, in thinking about these conditions, it's important to understand that the likelihood or the chance of having a condition may be different in different parts of the world. And so understanding somebody's background, somebody's travel history, their demographics, and their social cultural backgrounds may influence how we, consider our what we call differential diagnosis, or list of possibilities of what a patient might suffer from. In his case, it was a life-threatening condition that he was suffering from. And what he really needed was suppression of his immune system to reduce that inflammation in his blood vessels. And he ended up doing well on the right therapies. So this highlights the importance of accurate and timely diagnosis. The right diagnosis can get you to the right treatment. And unfortunately, medical errors in terms of diagnostic errors is one of the most common errors that is made in the healthcare system. It is also, of course, harmful as if you don't have the right diagnosis, or you have the wrong diagnosis, you may be getting treatments or interventions that you don't need, and you may be missing a life-saving or potentially changing therapy that you do need. And in some cases, there can be an urgency for that. The diagnostic process is what I wanted to talk about next, because it is not so straightforward. Typically, people think, okay, well, if I present to a doctor with such and such symptoms, based on their training and everything, you kind of think about the right diagnosis, and it's almost certain that that's the right thing, and you'll get the right treatment. But there's a lot of factors that go into how a clinician arrives at the right diagnosis. I wanted to demonstrate this. This is from the Institute of Medicine, formerly known as the Institute of Medicine, or National Academy of Medicine. And they put out a report in 2015 called Improving Diagnosis in Healthcare. And this was a really important report that talked about the diagnostic process, as well as the problems and challenges, as well as how we can move forward in improving diagnosis so that we can reduce errors and harm. And it's important to note that in the National Academy report, they define diagnostic error as not just the wrong diagnosis, but also the delay in getting to the right diagnosis, which is often an issue too. And so what goes into, the evaluation for a diagnosis? First, you have the clinical visit, right? That's where you talk with your doctor. And so they will perform clinical history and interview. They'll ask you questions. Like I mentioned for that case, asking the right questions was really key and critical in getting the right data to be able to synthesize the right conclusion. And then the physical exam findings, looking for certain signs and findings, perhaps on the skin or other places. And then, depending on the case, maybe we need to do additional testing, laboratory or imaging, et cetera, to be able. So after the physical exam and the interview, the doctor may have some ideas or some leading hypotheses, and then that might be confirmed or it might be refuted by certain tests that are run in the laboratory or imaging studies or other diagnostic studies. There also may need to be referral for consultation with certain subspecialists and subspecialists, especially when we're dealing with very specialized conditions or rare conditions as well. And so you can see there's a lot of information that needs to be collected. It needs to be accurate. It needs to be comprehensive. And it needs to be all synthesized and put together. They're like the pieces of a puzzle. And so that diagnostic team or that doctor or the team of doctors needs to be able to integrate all those pieces of information from the history, from the exam, from the testing, and maybe from its consultants, and then put that all together. So that's information integration and interpretation. There's, sort of the leading ideas. And then you may have testing that will tell you, no, that's not the case. You need to go back to the drawing board and think again, or ask more questions, gather more information. And it really becomes an iterative process, meaning this could be done over and over again. And of course, there's the communication, which is key. You need to be able to, understand from your doctor, well, what is it that they're thinking, and what is the, leading diagnosis or thought to be the thing that's causing your symptoms. And then if they're relatively confident and relatively certain that this is likely the cause, they'll give you a treatment, possibly if there is one available for that. And sometimes the treatment will tell you too what your response is and how likely it is that you have that diagnosis. If you don't respond, then perhaps it is also important to go back to the drawing board and try to understand, well, where did we, miss some information, or should we readdress some additional testing and additional consultations. So I hope this gives a good overview of the complexity, but also the iterative and cyclical nature sometimes that is needed to arrive at a refined diagnosis. And it's important that we recognize that there are many components to this. And it's also important to recognize that this is where the patient and the doctor can be a team, as well as the family members, caregivers, and other healthcare professionals can all come together to work as a team to make sure we have all the information and that we are completing this diagnostic process to the best of our abilities. So in terms of rare diseases, where are those challenges? Rare diseases are individually rare, but as a whole, they affect 30 million Americans and about 400 million people worldwide. This is, so again, individually rare, but collectively common when you put all the rare diseases together. In the United States, there's different definitions of what makes a rare disease based on different countries' definitions. But in the United States, it's roughly about 1 in 200,000 people is sort of the threshold for calling a disease rare. It is often missed or misdiagnosed for multiple factors, but this could result in potential harm. And some of it may be the lack of awareness, the lack of sort of training and education. And it's also, there are lots of conditions, and it's uncommon for any one doctor to encounter any one of these individual rare diseases. And so, it really requires a certain degree of expertise or knowing who to turn to when you encounter one of these cases. Certain rare diseases, and this is very relevant to the topic at hand, is disproportionately affect Asians and other minority populations. But many are not easily recognized by medical trainees or even practitioners because of lack of awareness, education, and also encountering them in practice clinically. Now, I will say that rare, as we were previously talking about defining as 1 in 200,000, is a relative term. So some conditions may not be that rare at all in relevant populations. For example, Behçet's disease, as was the illustrative case, due to genetic or social, cultural, or geographic factors. And this is where we need to understand those kinds of details about our patients and understand how those rare diseases afflict different populations. And in speaking of minority populations, it's really important to recognize and understand the health disparities that Asians and other minority groups face. And that includes lack of intentional focus of current medical education and training in Asian health and rare diseases in general. There's also historically been a lack of racial and ethnic minority representation in the medical literature, as well as reference textbooks. And it's also a known thing that there is underrepresentation of both women as well as minorities in clinical research. And really, these are the studies that are what provides evidence and data for us to define our practice and to be able to define the field of medicine. So, and there's also, of course, also structural racial inequities in the American healthcare system, including access and socioeconomic factors, resources, et cetera. And then, as in the case of the patient that I talked about, the Chinese immigrant, there are also language and other social cultural barriers that may impede or present challenges to the diagnostic process. You're trying to get the right information, but there's lack of trust or lack of communication that's clear. Information can get lost. Finally, there's also factors of cognitive biases and implicit biases that may be at play in evaluating somebody. And that's something we're all susceptible to. And, there are programs out there for implicit bias training and understanding stereotypes and how to get around that as we're trying to evaluate patients' cases and patients' symptoms as well. So, as you can imagine, I talked about rare diseases and the challenges with that. And then I talked about also health disparities. So for a patient of minority background suffering from a rare or underrecognized condition, these inequities and challenges are further compounded. And there are a lot of barriers that a patient might face when they have a rare disease and of a minority background. So, and we can also see some of that sort of access issues or perhaps referral issues. For example, in our own diagnostic clinic, this is data from our clinic over a 5-year span of period of time. It represents about 250 patients. And what we see is underrepresentation of Asian and Hispanic population in our clinic. And so in blue here is the percentage of our patient population or of our cohort that are of Asian or self-identified as Asian descent, compared to Stanford as a whole, as well as the local Bay Area, local regional census data. So one might ask, why is that the case? And could that also play a part into, why there might be underrecognized kind of diagnosis or underrecognized conditions that are not getting diagnosed properly? And there could be multiple reasons, including access or advocacy or, bias, as I mentioned as well. But this is definitely an area that needs to be further investigated. And so there, in that report of improving diagnosis in healthcare, the 2015 report from the Institute of Medicine or the National Academy of Medicine, they also talked about how can we, so now that we know all these challenges and barriers, how can we improve diagnosis? A couple of the points that I wanted to highlight include healthcare professional education and training and patient and family engagement in the diagnostic process. They also mentioned the importance of improving health information technology. That includes, for example, our electronic healthcare records, there's lots of data in there. How can we sift through it all or make it clinically meaningful, as well as always the constant kind of quality improvement and the safety checks and the feedback is identifying and analyzing and reducing diagnostic errors. And then there's also systems level issues that we need to be able to improve and external environment factors too. In our own diagnostic clinic, we really value sort of 3 principles as we approach difficult diagnosis or rare or pleasant conditions. And that I call the 3 T's. 1 T is time. And that's something that's a precious commodity in modern healthcare, right? When you go to the doctor, you may be crunched for time. You may have an appointment that's 15 minutes or 20 minutes, and you're trying to if you're trying to figure out a rare disease or a puzzling condition or a complex condition, that could really present as a challenge to both yourself and the doctor who's trying to diagnose you. And so that, for example, is a systems issue where, that time is precious, but it's not enough for us to be able to do a good enough job and do the full, thorough, gathering of really comprehensive information that I mentioned in the diagnostic process. And then the other one is team, and that's really important. I definitely think that as we talk about rare diseases and under-recognized conditions, no one person can know everything. And so having collective knowledge and collective intellect and crowdsourcing with your fellow doctors and colleagues, and of course, as a patient too, you have Dr. Google that sometimes you turn to, which may or may not be, the most informative thing, or perhaps it can raise some additional questions and anxieties. But being able to integrate and work as a team together is really important. That includes doctors with other doctors, as well as interprofessional teams with our other healthcare professionals, including nurses and pharmacists, et cetera. And also in partnership and as a team between patients and doctors together, right? You're both trying to solve a puzzle together, and patients are experts in their own lived experiences, and doctors may have expertise in certain medical conditions. And it's when those two come together, and that synergy is what really allows us to be able to solve a difficult, challenging problem. And there's also, of course, family members and caregivers who can provide a lot of information that may be key and critical to the diagnostic process. So at Stanford here, what we've been working on is these two highlighted things. So our goals are, one, to improve the knowledge and education aspect for our medical trainees, our medical students and residents, as well as practitioners, to identify the rare diseases that may more commonly affect Asian populations and improve awareness and recognition of these conditions, such as Behçet's disease. And then the other goal is to, at the same time, improve and empower patient engagement in the diagnostic process. And that may be difficult for vulnerable patient populations and minority groups. And so we want to identify barriers, challenges, and potential solutions. We're doing this with a community advisory panel made up of patients as well as family members, caregivers, advocates. And what we are trying to do is co-create toolkits that patients and providers can use to really drive and promote partnership with each other, and coming from a diverse kind of voice and understanding what minority groups might be encountering that are barriers and challenges, and also what patients with rare diseases might be encountering, and how to implement ways to kind of overcome those barriers and allow us to have those engaging, conversations and partnerships. So with these two goals in mind, and this is done with the collaboration and support of these organizations and institutions, including CARE, as well as Sean and Parker Center, as well as Presence and the National Academy of Medicine. And so some of our preliminary findings are from identification of rare diseases in Asian populations. And that our approach was to look at rare disease databases. And for those of you who might be interested in just looking into rare conditions or learning about rare conditions, both GARD and NORS, so the two organizations that I have highlighted here, have rare disease databases and patient-facing information. They're great resources, including NORD has also advocacy groups for certain rare diseases and patient support groups. GARD is hosted through the National Institute of Health. And they both contain databases where you can learn about certain rare diseases. And our approach was actually to go through those databases systematically and try to identify through search algorithms which ones may afflict Asian populations more. So we actually go by the continental Asian subgroups, including by country, as well as by ethnic groups. And in that, we were able to generate a preliminary list. This is still an active, ongoing project, but some of the diseases that came up from our searches include Behçet's syndrome, as was the illustrative case, as well as, for example, Kikuchi's disease, which is a rare condition that affects the lymph nodes or the glands in the neck. And that can often be misdiagnosed as a cancer or as an infection, but Kikuchi's is neither of those. And so it's important to be able to recognize that. And melioidosis, that's something that a lot of people haven't heard of, and that's an infection. So these are different types of conditions, but it gives you an illustrative idea of, rare or under-recognized conditions that may disproportionately afflict Asian populations. This is an infection that is more found in certain tropical areas, including Southeast Asia, and it's caused by a bacteria, and it can lead to tuberculosis-like symptoms with fever and rashes and pneumonia, and can also have other manifestations. Now, this is an important point too, is when in trying to identify these conditions, these are not to put these conditions in a box, right? It's not saying all Asian individuals have these, would have these conditions, and if you're not Asian, that you don't. That's not definitely not the message that we want to drive across. What we were trying to highlight is that these are all different types of conditions, and it may be disproportionately afflicting Asian populations because of an exposure. Some of it may be genetic susceptibility, or in the melioidosis case, it's really about geography and your risk of being exposed to certain bacteria. And if you're an immigrant from that area, it's not necessarily about your quote racial makeup per se, but it's really about your geographic background and your prior where you lived, and that might correlate with your race. But it's important to separate that, because we don't want to perpetuate the idea of race-based medicine as we're moving towards, individualized precision health. And then the other one that I thought was interesting too that came up was gastric cancer, and that's very relevant to a couple of the other talks that were given by, I believe, Dr. Andrew Lee and Dr. Huang from gastroenterology in this care series. And they gave great talks about the increased risk of gastric cancers, which are generally more rare here in the United States, based on majority, but increased in Asian populations, especially in East Asia. And so those are some of the examples, and it's important for us to be able to then educate and raise awareness of these conditions and ask the right questions for our patients. Then going to our second goal is, how do we then improve the engagement of patients and their family members in the diagnostic process? And here, there are several points. And the highlighted points, these are based on information that is already known from the literature, as well as interviews that we've done with our diverse patient and community advisor panel. So the first is be prepared. And that means when you go into visit, especially because time usually is a limit, you want to make sure that when you're going to a doctor's visit, especially if you have a puzzling condition or, the diagnosis is the question, you want to make sure that all your medical records are up to date and they're organized, and you want to be prepared with your questions and your concerns. What are your symptoms? What are you most worried about? And if you've kept a timeline of the occurrence of these symptoms or the times of events and the kind of important time points, that is really important too. And also your medications, which often the medical records just aren't up to date or accurate enough to be able to be as informative as we would like. In this, number one point to be prepared, there's actually a toolkit out there already. And please explore this through the Society to Improve Diagnosis in Medicine, which is a really phenomenal resource for patients and providers alike. And this can be found at improveddiagnosis.org/patients toolkit. And this is an example. This is just a screenshot for part of their toolkit. And so this is something you can print out. You can write this down, and you can see, to prepare for your appointment, you want to make sure you have your medical history. What treatments have you tried in the past? Did it help? Other important dates? What are your top concerns? What testing have you done? And of course, we would hope that the medical records in the electronic healthcare system is accurate and has all of this information. And sometimes it does, but especially if you're going between clinics or to different institutions, sometimes, seeking second opinions, it's really important that it corroborates with your own records, and that you have the records to be able to give to your new or consulting physician. And so that is a really important example of way to organize information to bring to your doctor's visit. The second point is to ask questions and not be afraid to ask questions. Historically, I think there's always been, that's been a challenge for some patients. There's sort of that stereotype or the view that the doctor knows everything and they're the expert. So I'll be more passive and absorb the information while they tell me what's wrong. But, I think as we move towards patient-centered medicine, and there's a greater emphasis on patient engagement, and I think it is important. Like I said, patients, you're the one who's living the experience. You have that, your body. Although you may not know the condition, you know your body best. And so make sure to bring up your concerns, ask the questions that you have. And then usually when the doctor talks, back to you about their thoughts, sometimes jargon is common, and using medical terminology that you might not understand. So that's important to make sure that you definitely ask, could you clarify that? Would you mind explaining that again? I didn't really catch that. Or, just making sure you understand everything clearly, including their ideas. And also, what are the next steps? Do you understand what the next step is in terms of testing? And what if you try treatment? What are you going to do if it doesn't work? What's your follow-up? And all those things are really important to get clear. And then the one other question I think is pretty important, especially when you're thinking about diagnosis, is you may ask, what else could it be? As I mentioned before, diagnosis isn't always certain. In fact, many times it's not 100% certain. And most doctors are there. It's okay to ask your doctors. I think, I would be candid and say, it's likely to be consistent with this. We want to confirm that with testing. Treatment that might support that, that's totally fine. But then it's okay to think, well, what else could it be? And that open up and create avenues to explore other ideas. This is also from the toolkit, and they have a list of different questions that you could ask as well when you're working through a diagnostic puzzle with your physician. The what else could it be, as well as asking about getting written information, a reliable source of information about your diagnosis, and also about the follow-ups and what to do if-thens in terms of if you don't improve with treatment. And then finally, another big point in terms of engaging more in the diagnostic process is advocating. And that includes advocating for yourself. So speaking up. If you're not really comfortable with something, express that. Make sure your doctor understands what you're worried about, because sometimes it's not clear. You may be thinking, oh, I Googled something and that's what I'm really worried about. And it's okay to say, well, I Googled that and I wonder, is this something that we should be worried about? Or if you spoke with somebody and you want to present that concern too. And sometimes, different people have different comfort with medical terminology and healthcare literacy. And so if you have a family member or a caregiver or a friend who may be more comfortable or familiar with the healthcare system, or even in the healthcare system, healthcare professional themselves, it might be beneficial for that person to go with you on certain visits, or at least key crucial visits where you're discussing a potential diagnosis. And seek and make sure to have follow-up. because follow-up is really important. As I mentioned in the diagnostic process, it's really iterative. And so it may be one idea, and then the testing comes back and doesn't support that. So you may need to go back and rethink, or you do a treatment and you need to go back and it doesn't work. So you need to work with your physician again. And sometimes new symptoms arise, new information comes around. And it's really important for your doctor to know that, so that they can have an ongoing, thinking process about that and update their diagnosis if needed. And finally, seek resources and support groups, as well as second opinions if needed. There are, like I said, NORD and GARD are great, reliable resources. Sometimes on the internet, there's all kinds of things that may be not valid or reliable. And so you do want to be careful, where you look. Typically, if you find information from, good, reliable resources such as the National Institute of Health, NIH, or CDC, Medline, those tend to be reliable sources of information. And support groups are great as well, especially when you're dealing with an under-recognized or rare condition. It can feel very isolating. And so that's important as well. And the seeking second opinions, I think that's one that when we interviewed a lot of our panel, they said, it's hard because you don't want to offend the doctor if you want to seek a second opinion. And so asking it in the right way might be helpful. If you're reaching, sometimes a doctor will say, I'm kind of running ideas. I think I would like to have you see, so-and-so, or seek a second opinion from this type of specialist, et cetera. And that's actually not uncommon. On the other hand, if you're having to drive that conversation, you could also ask in a very, kind of diplomatic way and just say, it seems like maybe it might be helpful to get additional ideas. What do you think? Should we, and just say we as a partnership, seek additional or get a second opinion, and ask it as a question? And that might be helpful to open up that conversation as well. And so to summarize the key points here, an accurate diagnosis is very important because if you don't get the right diagnosis, you might not get the right treatment. Diagnostic errors are unfortunately quite common, so we really need to improve the diagnostic process. And the diagnostic process, as illustrated by that diagram, is quite complex and it's iterative. And so follow-up is really important, and teamwork and partnership with the doctor is really important. You bring something very valuable to the table, as well as possibly others who can contribute to that teamwork as well. Rare diseases are under-recognized and difficult to diagnose. And we have a lot of work to do there to raise awareness for these conditions. And then Asians and other minority groups face additional challenges and barriers to getting to the right diagnosis because of health disparities. In two ways that I had demonstrated in terms of our goals for working on this area is, one, to raise awareness of these rare diseases through the education and training and identification of some of these conditions. And second, to promote that patient-physician partnership, because again, coming together with the expertise of your own lived experiences and the expertise of that of your physician and your doctor, that's really where that synergism comes, and that partnership can really lead to great results. And that trust is so important to be able to go back to the drawing board if need be. And finally, I'd like to just thank you for your attention, but also to acknowledge our consultative medicine diagnostic team, as well as all the research students that have been working very hard and contributing to this work, including the care scholars and other mentees, as well as our community advisory panel, who really offered and shared their barriers and challenges and offered tremendous insights through their experiences. And of course, our support, the support of the institutions and our collaborators as listed. So thank you so much.
Great. Thank you so much, Dr. Geng. What a wonderful, insightful talk on a very important topic. I would like to encourage our audience to put any questions in the Q&A. and then we will discuss them with Dr. Geng. I'd like to kick off the session with my own question. What do you, I know you covered a lot of this in your talk, but you've seen 100 doctors, and we have patients who've seen 100 doctors, and they've big binders of information. What do you do? What's the next step after you've seen so many physicians? How do you make sense of what's going on when you get so many different opinions?
That's a great question, and definitely very challenging. And this is what I mentioned about the uncertainty of diagnosis sometimes. There's a couple of things, especially, and we do see patients, in the diagnostic clinic who have gone to multiple institutions, who've seen tons of doctors, perhaps even gotten conflicting diagnoses. And this is where being, able to accept at one point that maybe we've reached the limits of medical knowledge on that. Medicine is very vast in its knowledge, but we're also still learning and actively growing our collective knowledge about certain conditions, and certain diseases are still being defined. Even illustrative as now in the pandemic, many of you likely have heard of long COVID or COVID long hauler. It's, although we've known about post-viral syndromes, even now there's clearly, this highlights the limits of certain areas of our medical knowledge, and research is needed in this area. So one is coming to terms sometimes with the unknown. And then the second thing that I like to also emphasize is, while of course getting to the right diagnosis is very important, and I think by the time you've seen a lot of smart doctors, the important thing is you don't want to miss a sinister diagnosis, right? One that is dangerous. And so in going through that process, if those have been excluded and we're left with some questions, then sometimes, assuming that a thorough evaluation, I assume, has been done, with the guidance of the right team, thinking about and trying to focus on symptom management might be the best next strategy. Sometimes that can actually offer diagnostic clues too, because even though we don't have a name for that condition, or there may be a couple of different ideas, the way that we treat a symptom or manage a condition might offer clues about, is it an inflammatory process? Is it an infectious process? If it's inflammatory, maybe we can try some anti-inflammatory medications, and that would help your symptoms and provide us a clue that that's really what is going on. So oftentimes, those are the two kind of ways to approach it that I do with my patients. If they've seen 100 doctors and still there's not a clear answer, is one is coming to terms with the uncertainty in medicine, assuming that all the sinister and dangerous things and important things have been evaluated for thoroughly. And then also, two, is trying to address and manage the symptoms.
Great, thank you for a wonderful response. Challenging issue. We have a question from the audience, Adrian Arima. Is an Asian patient better off having an MD who's also Asian? So kind of race ethnicity concordance. When my son was 2 years old, he was misdiagnosed until we took him to an urgent care center where the on-duty MD was Asian and instantly suspected he had Kawasaki's disease, which turned out to be the correct diagnosis.
Wow, thanks for sharing that personal story. And that is definitely an illustrative case of an underrecognized condition that can disproportionately afflict Asian populations. So, there is data to support the idea that racial concordance between the provider and the patient may be beneficial in clinical interactions and possibly even diagnosis. The idea behind that is improving trust, empathy, and building that connection, which is so key and important in any therapeutic relationship that you have with your doctor. Having said that, though, I think that is definitely a very blanket statement, right? I think I think we need to do training and additional awareness, for example, for Kawasaki disease and other rare conditions or underrecognized conditions that may afflict different populations in different ways. And that's something I think all doctors should be able to do. And we should try to increase and improve that in all doctors, regardless of your ethnic or racial background. But it is true in interviewing our own panel of diverse patients from various ethnic backgrounds that was a common theme that came out that said, they felt in their report to us that they received better, a more kind of better connection. They had better trust with that physician. And trust is so important, because if that's a barrier for you, then you may not reveal critical and key pieces of information to your doctor that would be key for diagnosis. And that's where the trust is really foundational. And so that can be a barrier, and some of that has been expressed by our community advisory panel. I do hope that as physicians and trainees, we learn more about cultural, competency. We try to break down some of these barriers. And it is my hope that eventually we'll all also be more knowledgeable in all aspects of diverse care. And that racial concordance might be less of an important factor, but it is a factor that has been recognized.
Great, fantastic. Next question from an anonymous attendee. Doctor, are you aware of any rare diseases associated with low platelet counts and enlarged spleens, especially in Asians?
Oh, that's a good question. So there are rare diseases that can be autoimmune. For example, there's an Evans syndrome that can have low platelet counts as well as low blood counts, and it's thought to be autoimmune phenomenon. But to my knowledge, at least in our search, we had not initially came up with a specific one that deals with the low platelets that disproportionately afflicted Asian populations. Having said that, it's not a comprehensive search. So those rare disease databases that we look through, NORD and GUARD, are not comprehensive. There's estimated about 7,000 rare diseases. And for example, NORD, I believe, only has a couple of thousand of those 7,000. So it's by no means, there may be one out there that disproportionately affect Asian populations. But to my knowledge, for example, Evans syndrome does not have a predilection for certain ethnic populations.
Great. From Zaji Song, rare diseases are rare in isolate but common in aggregate. However, there's so much disease a doctor knows, and even fewer hypotheses may come to a doctor's mind at the particular moment. Do you think big data and machine learning can greatly assist the diagnostic process of rare disease? Because I imagine with this approach, you can enter multimodal data and look for a match in large databases of rare disease. Is data science and machine learning currently clinically implemented in any way to improve the diagnosis of rare diseases?
Wow, that is a phenomenal idea and question. And certainly beyond, in terms of my level of expertise, I'm not a machine learning expert, and I'm not a data science, like an informatician. However, I will say I definitely agree with you that there's so much incredible potential. And this is actually the area of active ongoing work. And I actually, when I said the 3 T's, so technology is really important. And that technology includes being able to digest large amounts of data. We have tons of data in the electronic healthcare record. And I know there are groups out there who are working on being able to sift through that data, mine that data, and make it clinically meaningful and valuable. That includes, for example, looking through for patterns that might be suggestive of a rare disease. So maybe even before a doctor sees you, the machine learning algorithm could look through records and pick up individuals who might be suffering from a rare disease, perhaps because of the certain medications they're on, or their test results, or their clinical history or symptoms, whatever data might be crucial to providing those keys. So that's one example. And then the other examples, there are, for example, a Stanford group has developed a way to query clinical questions based on a whole data set of electronic healthcare records. So you might ask, if somebody has X, Y, and Z symptoms, what did other patients end up having in terms of their diagnoses? And so that kind of assisted clinical decision making and assisted clinical information processing is really important, and really, I think, a way of the future to be able to augment and complement our individual, doctor minds we can only process so much as humans, but the machines can do so much more. And when we marry our creativity and our partnership with our patients and our humanism with the technology, I think that's really where things can be quite powerful. Of course, that also comes with a bunch of other issues and certain challenges and ethical considerations as well. That could be a whole nother topic of discussion, but I think there's great promise and there's work being done in this area, especially for rare diseases, because we really need to be able to mine the data and understand, can we pick up patterns? Can we accelerate the diagnosis and not delay the diagnosis of rare and underrecognized conditions? So there's great potential to be done there.
What a fantastic question and fantastic answer. Question from John Wang. Autoimmune disease are either on the rise or perhaps is this just being better recognized? Which is it? Increased diagnosis or is it becoming more common?
That's a great question. I don't know the full answer to that because I don't know if there has been increased necessarily like that we know. It's hard to distinguish, right? So for example, for rare diseases, and I don't know, maybe the data is out there that clearly there is a spike in the prevalence, but for rare diseases, the prevalence is often hard to nail down because as you were pointing out, if you know about it and think about it, you might diagnose it because there are many people who may, if it's not a condition that declares itself so radically or so severely that, you either, might be in the intensive care unit or you have to you push the medical system to be really, you have to diagnose it. It may go undiagnosed and undetected. So that kind of prevalence, we found that prevalence can be tough to accurately estimate, especially when you're dealing with underrecognized conditions. In our database searches, we've discovered that, for example, there are a lot of rare diseases in Japan for some reason. And we thought, is this just a high incidence of these rare conditions in Japan, or is it that the Japanese medical community and healthcare system really keeps great records of rare conditions? And so are there other confounding factors, including recognition of those diseases or, possibly being able to keep better healthcare systems and records and epidemiology? So I don't know fully the answer to that, but I think definitely increasing the awareness will help to improve the diagnosis of these conditions.
Great, fantastic question. I'm going to add a question of my own. You're running co-running the long COVID clinic at Stanford. Your thoughts of that and other similarly presenting syndromes like chronic fatigue syndrome. Any insights on etiology or improvement in management?
Right. So this is an exciting and active area of research and investigation. And I sort of mentioned that as an example of the sort of, it highlights an area of neglected medicine, I think, because chronic fatigue syndrome and other post-viral syndromes, as we've also analyzed our own cohort of diagnostic kind of puzzling cases, actually a good portion of those patients had what was potentially a triggering infection. So we see a lot of post-viral syndrome type patients in our diagnostic clinic too. So it comes up as a puzzling condition. And now the pandemic has shed a light on this neglected area. And in terms of long COVID in particular, there's definitely features of it, right? Long COVID is persistent symptoms, at least for 4 weeks. Some people define it as greater than 12 weeks, so about 3 months out from their initial COVID infection. So by 12 weeks, you should have had time to recover from the sort of, if you were hospitalized, that post-hospitalization kind of deconditioning, those symptoms. But people can have, even if you had a mild or moderate infection, can have fatigue, can have brain fog, dizziness, headaches, sleep disturbance, and persistent smell and taste disturbances, and shortness of breath, chest pain, all these complex symptoms. And what we've found so far, we collectively, I mean, nationally and globally in terms of studies, there hasn't been really clear, there's not like a diagnostic test. There's usually not clearly a lot of correlation with, you can do a bunch of testing and they may not show necessarily significant abnormalities. So it's a puzzle because some patients are so debilitated, they can't even work, they can't even do their daily activities. A couple of the leading hypotheses about what might be going on, but more research is needed. This is a big caveat. We just don't understand. We just don't know yet what is truly happening. But a couple of the leading ideas is a persistent inflammation. So thinking about autoimmune diseases, maybe this is some sort of autoimmune phenomenon or autoinflammatory phenomenon where, you had the initial infection, the virus is in your system, and your immune system was active as it should be to try to get rid of and fight that infection. But then after the virus is no longer a threat, the immune system needs to shut down in terms of that activation and go back to its normal state. But perhaps there's, for some individuals, that hasn't completely shut off. So the idea is a persistent dysregulation or abnormality in inflammatory processes, so a low-grade inflammation or an immune process. There are a couple other ideas too. So this is an active area of research and investigation. And we hope that researching and understanding long COVID can also have implications for other post-viral syndromes, which have really been puzzling for many, many years and in other domains as well, like chronic fatigue syndrome.
Great. Well, thank you so much for your fantastic talk today. I would say a great congratulations for running your clinic. I know how difficult it is to see complex patients from personal experience. I'm going to close with a comment that I would like to say thank you to Dr. Geng and her clinic. They were the only clinic who took their time to listen to me and to review all my images. I saw so many specialists and underwent unnecessary procedures prior to seeing Dr. Geng. Dear Dr. Geng, all the best to you in your medical and academic career. I'm proud that we have at Stanford such intelligent, compassionate professionals like you. So great kudos, Dr. Geng. Any thoughts on her comment in terms of just, how helpful the active listening is and a second pair of eyes?
Wow, thank you for sharing that. That is such an incredible comment. I hadn't heard that one before from her. So that is I'm so grateful. And seriously, I'm very serious when I say we learn so much from our patients too. And listening is so important because it's that synergy. I think I mentioned this multiple times of patients bringing their expertise on their own bodies and experiences. And then, coupling that with a scrutiny and look at, as a second time, just looking at all the details again, and really having that time, and then the team to do that together. It wasn't just me; it was the whole team working on it together and bringing different perspectives and thinking what else could be missed. And I'd also like to say sometimes, even if we sometimes don't come to a magical conclusion or a clear answer. I think it's so important, just like for long COVID patients who we still don't have a clear cure or full understanding of what's going on, is to validate patients' experiences and to know that especially for patients with puzzling conditions, it can sometimes patients can feel dismissed. And so we also need to understand and validate that what you're experiencing is real and it's what you're experiencing. What the diagnosis is maybe is something we need to work on and think about. But no one can take that experience away from you. You should always feel like what you say is valued. And so I hope that all the patients I interact with and encounter, that they feel that level of kind of respect and also, I feel it's a privilege to be able to try to help and work together as a team.
Great. Thank you so much, Dr. Geng, for a wonderful talk and being the co-director of our consultative medicine clinic. Thank you for the audience for spending a worthwhile hour with us. We are not going to have a talk in December, but we will resume in January. So please stay tuned. Check out either the Stanford Health Library website or the CARE website, care.stanford.edu, for information as we post it. Thank you so much. Have a fantastic week.
Thank you.